Okay, I think we'll go ahead and get started. All right, so welcome everyone. This is Health Information Exchange, a vital component of Montana's healthcare future. The webinar is hosted by Big Sky Care Connect. My name is Drew Hensel, the Big Sky Care Connect program lead, and I will be facilitating today. So just a couple of housekeeping items before we get started. I'm going to ask that everybody keeps themselves on mute unless you're speaking. And if you have any questions at any time during this presentation, please don't hesitate to use the chat feature right here within Zoom by clicking the chat button and typing your question. We have folks that are monitoring that chat, and they will go ahead and answer you in the chat or go ahead and pose the question to our speaker or technical team for the answer. And I also want to remind everyone that this webinar is being recorded, and the recording will be made available in the next couple of days as soon as it's available. All right. So before I turn it over to our speaker today, I just wanted to thank all of you on behalf of Big Sky Care Connect for taking the time out of your busy day to learn more about your statewide health information exchange. So as some of you may know, BSCC was designated the statewide HIE by Governor Bullock in 2019. And we do have support from CMS 9010 funding that BSCC is covering all costs of onboarding and implementation through September of 2021, which is quickly approaching. So what that means is that starting October 2021, those that wish to sign up and participate in Big Sky Care Connect will cover their own cost of joining. So I strongly encourage you to start the outreach and onboarding process with us if you haven't already done that. So just a little bit about some of the services and value adds of our BSCC offering. So we have already partnered with Collective Medical and Dr. First. And what we found with Collective Medical is that there was a large amount of interest in the emergency department community for an ED alerting service. And then also for Dr. First, through that partnership, participants will have insight to a patient's medication history, including data for prescribed and dispensed medications. And just progress of the overall platform, we have chosen InterSystems as our technology platform provider, and we are currently progressing through user acceptance testing, both of the user front end and the technical back end. And we anticipate that the platform will be ready for go live during the fall of this year. Also, on the participant update, so this is actually, we are up to 12 facilities in Montana that have signed, and of those facilities, they include larger health systems, critical access hospitals, federally qualified healthcare centers, long-term care, behavioral health, specialty clinics, and payers. And really what all this means is that BSCC is a sustainable and valuable resource for Montanans by improving healthcare quality, making care more efficient, streamlining administrative tasks, engaging patients and supporting community health. And if you're interested in hearing more and signing up to participate with Big Sky Care Connect, please reach out to us, and we have an outreach team that's ready to assist you through that process. Contact information will be on the end of the presentation, so you can feel free to send us a private chat with your contact info also within Zoom, and we'll be in touch. And without further ado, I'd like to introduce you to our speaker for today. So, Dr. Gary Ozanich is a nationally recognized expert in the fields of health information technology and health information exchange with more than 30 years of experience. He is the past national chair of the HIE Committee for Health Information and Management Systems Society and co-chair of the Interoperability and HIE Community Committee. Dr. Ozanich was the founder of and is the current director of Northern Kentucky University's graduate program in health informatics. And he currently serves on the board of the Kentucky HIE and is on research teams for 2 federal projects, electronic health record reporting and ASPE's measuring interoperability in value-based care. So after that introduction, Gary, I'll go ahead and turn it over to you.
Thanks so much, and it's a real pleasure to participate in this webinar today. And I think what we're going to talk about today, you'll find interesting in that what we really want to do is provide an understanding of the complexity and many of the challenges in data integration and data interoperability, but also most significantly the solutions that are currently being introduced into the marketplace and some of the new public policies that are, have a direct effect on value-based care reimbursement, and also the general willingness to break down what were historically walled gardens between provider groups or between provider organizations and types of providers. So our agenda quickly, we'll just talk a little bit about HIE and data integration, and then some of the market drivers and the solutions, and happy to take questions at any time. So team, feel free to stop me at any time and ask me questions. So obviously, as we have moved into what's really a new world of value-based care and reimbursement that is really moving quickly upon us, it's increasingly important to be able to have interoperable data, that is data integrated from a variety of locations, not only to see the complete patient record, but also just to better coordinate care and drive better outcomes. And we've had some bumps in the road, and we're going to talk quite candidly about those bumps in the roads. But one thing I'd like to point out about Big Sky Care Connect is this is a comprehensive system, and I'll mention that the vendor selected InterSystems is also the vendor for the National eHealth Exchange system, and this is going to become very important. Well, first off, it really speaks to the quality of the technology they've implemented, but also speaks to the whole general support of interoperability and exchange. So, we have the various stakeholders we want to connect, obviously, but what we need are various technological pieces to allow this complete patient record to be assimilated and usable, and support general coordination, and of course achieve the goals of the value-based system reimbursement models. So let's talk a little bit about data integration. This is from a recent study that I got to be a co-author on for the Office of National Coordinator. And we looked at data integration. Now, not data interoperability, right? Data interoperability means two computers can talk to each other and they're able to swap files in a coarse sense. But what we're really interested in is data being integrated between trading partners? Is data being integrated into the electronic health record in such a way as it can be used? It's one thing as the Meaningful Use and Promoting Interoperability program required interoperability. It's a completely different thing when we're talking about actually integrating and using the data. So this is based upon 3 different research studies. We were able to get to the primary data. And just to give you a sense of the ability to send and receive data, well, obviously, a hospital, an acute care facility is going to be using, likely a more sophisticated vendor, whether it's Epic or Cerner or Meditech or whomever. But once we start moving down into the office-based physicians, the ambulatory physicians, you could see that data integration is just not occurring, right? And home health agencies have a somewhat higher degree of reported integration, but the level of sophistication for the data being integrated isn't nearly as great, right? I mean, it's mainly between a portable computer, a laptop computer, and a visiting nurse more than any other use case. And then if we start looking at skilled nursing facilities, long-term post-acute care, that's really where we have a substantial drop-off. One of the challenges we've had in healthcare is when the incentive programs like Meaningful Use were introduced, they, of course, did not include long-term post-acute care, nor did they include behavioral health. So if a facility like a long-term post-acute care facility, more than likely they're using electronic health record from point-click care or Matrix Direct. They've got about a 70% market share, and they're not certified to the most recent 2015 ONC standards, so they have a limited ability to integrate data. Now, there is a solution coming for long-term post-acute care that we'll talk about in just a bit. So obviously, data integration is critical to value-based care. You have complex patients who are seeking care across systems. You know, whether that number, you know, I've always heard, although never been able to document, a national number of leakage of about 30% of your patients will leave a system in a given year to seek care outside your system where you're not going to have a complete record of. And obviously more complex patients, particularly those who use the ED department more often, or perhaps are seeking care for a variety of issues, may be moving outside of the system. So obviously just being able to capture data across systems is critical. Also critical is the ability to integrate the data into the workflow. Workflow is still the major barrier we have to so much of the problems of effectively using data. And so one of the key pieces, of course, is being able to map data seamlessly after you exchange it. Reimbursement obviously is linked to population health and patient outcome measures. That of course gets everybody's attention. And then we're looking at key uses like registries, quality measure reporting, and if we've just seen what's happened in the COVID pandemic issue, the ability to track patients across registries, integration with public health is critical. ECQM, quality measure reporting, is linked to reimbursement now for Medicare patients, and very important. So there's a lot of data exchange and integration that are really, really critical. And ultimately, what you want to do is populate your clinical decision support systems and predictive analytics effectively with the most complete data picture you have. So there are challenges. We have the challenge of technical interoperability. Can two computer systems talk to each other? We have the problems of semantic interoperability, and that's really a huge issue. Really today, it's a bigger problem than technical interoperability, which is working out the data dictionaries and in effect the data mapping between systems. Then we have workflow integration. And of course, as we're looking at getting a complete patient record, there's the data characteristics. Once you start attempting to bring in data from behavioral health in particular, or various social agencies, you're going to be dealing with a lot of unstructured data, social determinants of health. Now I know there are a lot of quite interesting solutions out there, such as by Epic, using checklists, trying to capture social determinants, and that really sort of semi-structured, but even checklists are not that easy to work with. So structured data, of course, is like a clinical measure. It's like a blood pressure, right? It's like a number. Unstructured data, think of it as free text. Think of it as your note that you write. And then semi-structured, think of it as a checklist when you check the box. And so we have to try to integrate all three of these. And that's really the role of health information exchange to enable. So let's take a quick look at what's happening in the market drivers. First off, we've got technology is shifting. We're very much at an inflection point. Standards and policies are very much being redefined. You've probably heard of the Cures Act, and there are various components of the Cures Act that are basically changing and laying a groundwork for more effective interoperability. Application programming interfaces, APIs, we're going to talk about in just a little bit, but they're really a key solution as we look forward to the usability of data by providers within their workflow. We're seeing some point-to-point transactions, and what else is happening is we're having national networks. I mentioned that InterSystems is the vendor for the national network called the eHealth Exchange, and they are able to provide connectivity actually to the VA, connectivity to the federal agencies, and so there's just a much more robust network coming in place. Vendor networks, if you've worked with Epic or use Epic, you probably have heard of Care Everywhere. That is Epic's proprietary health information exchange network that allows you to query the Epic customers for a patient to see if you can aggregate data from them. And we'll talk a little bit about vendor networks. But the idea is we're going to try to leverage all of the stuff that's occurring to rapidly provide solutions and basically encourage competition and transparency in the marketplace. So as mentioned, key is the movement to value-based care and risk sharing, pop health and data analytics. It's really becoming a reality. Data warehouses and data lakes, the ability to aggregate registries and support public health. One of the key issues with registries I'll mention, and this is why state HIEs are so important, is each state agency has a registry, right? Basically a database that is use specific. You know, it may be an immunization registry, which I'm certain you're familiar with, or it may be a cancer registry. But the idea is that each state has their own proprietary registries, and they expect the providers to provide data into that registry. Well, there's also federal registries, which are probably, I mean, they're glorified registries, MACRA and MIPS, you know, the value-based payment models out of CMS. But that's easy for a vendor to tailor an EHR for, right? Because all of the electronic health records have to deliver the data nationally to the feds. But if you start looking at state-specific solutions, it becomes a very expensive endeavor, and there's no way that the EHR vendors can provide scalability. That's why a health information exchange interconnection with the state is so important. Then payer engagement and financial decision support is critical. As mentioned, you have the Medicaid. You're seated with Medicaid data, which is very important. And then the standards, and then ultimately consumer-directed exchange that we'll talk about. So what's going on in the marketplace? Well, what's going on in the marketplace is Epic's Care Everywhere is still the dominant solution. More data are exchanged through Epic Care Everywhere. If you look at the data, Epic will claim, or the ONC indicates that Epic has a 35% market share, but that's not based upon lives covered. That's not based upon lives they see. That's based upon the number of locations that have Epic, right? And you have to have some size to do it. And Epic's Care Everywhere is an interesting solution. And one of the things that's really interesting and somewhat frustrating about it is that it does not use existing standards. It uses Epic-specific standards. They've indicated that the standard for exchange that was in effect when they built out Care Everywhere and developed Care Everywhere, the Consolidated Clinical Document Architecture version 2 was not robust enough to support the type of exchange they wanted to have. So it's interesting out there. Epic is doing its own thing. We talked about the eHealth Exchange, and I'll refer to that as the EHX, and that's the National Health Information Exchange that's currently being developed on the InterSystems platform. And that's where you get connectivity to DC. That's where you get connectivity to VAs on a national basis. Alert services, Drew mentioned, a Collective Medical, which is another, really very well thought of company that is providing admission discharge summaries and other type of alerts. The thing is, alert services are becoming increasingly competitive and commoditized. So health information exchanges basically are providing it, but what you're finding is in many states, not in Montana, but in some other states where I do work, you have entities such as a medical association or the hospital association come in, and they're providing their own service to their members. So that's an interesting market space to watch, not so much in Montana, but in the bigger states. And every health information exchange business model is based upon document exchange and alerts, but you have to do more than that. You have to, as Drew mentioned, you have to be focused on solving the problems of your customers. And ultimately, the Cures Act, if you're not familiar with the Cures Act, that was passed at the tail end of the Obama administration. And what the Cures Act was designed to do is really correct many of the inefficiencies created by the Meaningful Use and High Tech program through new legislation. There's some really interesting parts of the Cures Act. I'm working on one of them, as Drew mentioned, the Electronic Health Record Reporting Program, where we're trying to bring better transparency into EHR products and vendors, and also drive innovation in that market. But there's also this very interesting element, which you may be familiar with in the Cures Act, that basically says all electronic health records have to make their, vendors must make their product available to third-party aggregators. And they use APIs. We'll talk about APIs in just a second, but it's a basically easy document way to exchange data. What will be evolving is you'll have aggregators like Google or Facebook or even specialty companies basically getting consumers to sign off and give them permission to capture their data, and they'll be able to aggregate their data, and they're not HIPAA constrained. So it's an interesting issue, and the rules that came out March 8th actually specifically address those HIPAA issues. So you have potentially third-party aggregators who don't have the same privacy requirements that providers face. So it's an interesting world out there. So the local regional HIEs, not statewide, because statewide has scale. But what we've had in this country is we've got 100 HIEs. And the local HIE in the region, they're basically being broadly diminished. What's happening is you've got healthcare systems consolidating. You've got vendors such as Epic providing Care Everywhere. You've got Cerner providing Commonwealth connections. You have a variety of ways. You have, in some markets, competing ways to do alerts. And then you also have the eHealth Exchange coming on board. And the vendors will provide connectivity to that national structure. So the local HIEs, not the state, but the local HIEs are having an absence of economies of scale and scope. They don't have the broad scale integration that's necessary. They tend to be capital constrained. They don't receive federal funding as a rule on a match basis. They're not tied in with Medicaid. So they're sort of left with low margin, high maintenance market segment, right? Those aren't part of a large hospital system. And they also have a challenge of finding and affording technical talent. There's a big demand for people with experience in interoperability. And I'll just point out that the most successful regional health information exchanges in the last 4 months in Indiana, in Michigan, and in New York State have merged, because you just don't have the scope or scale on a regional basis. They also don't have the ability to work with the state, right? They don't have the ability to integrate with Medicaid. They don't have the ability to have other funding opportunities. So there's really some great opportunities for HIEs. Gateway to the state, as I mentioned, this whole registry problem is huge. We held focus groups across the country last year for the ONC, and what providers said, number one was interoperability. Number two was, I can't connect to my state registries, and my vendor won't connect me to my state registries, or my vendor wants to charge me money to extract the data so that I can send a flat file to my registries. So there's an obvious role here, and particularly to be integrated with Medicaid and also state agencies. The pandemic, I think, has really shined the light on the problem with public health integration. Public health tends to be not even organized on a statewide basis, but tends to be very local, with local or county offices or regional offices underfinanced and making decisions independently. We've also learned a lot about the problems of lab integration, and LOINC is the standards that's used for exchanging lab data. LOINC has been around for 20 years now. It was developed by the Regan Street Institute up in Indianapolis. And I live in Cincinnati, that's why I say up in Indianapolis. The LOINC standard is still not ready for prime time 20 years in, and then SNOMED is sort of the clinical language equivalent of ICD codes, and there are a lot of SNOMED issues. And how do you do registries, syndromic surveillance, and just even on next Tuesday, there's a funding opportunity that closes for health information exchanges to pursue some additional funding, particularly that's pandemic. Registry reporting, I think I mentioned. Data reporting and analytics. A lot of providers don't have the scale or can't afford what their vendors are asking in terms of doing data reporting and analytics. So you do see some health information exchanges moving into that area. Patient matching is always a huge problem. And as health information exchanges do upgrades, such as Big Sky has done, they likely have a better patient matching solution than most providers out there and most health systems. So there's a service, and then of course telehealth. I'll pause here and see if there are any questions, or feel free to interrupt me at any time. Okay, well, I'll briefly talk about one piece of the Cures Act here. And the Cures Act, as I mentioned, is trying to fix a lot of the problems, or I shouldn't say problems caused, problems that were not addressed, or issues that were not addressed in the first round of funding of meaningful use and just generally the High Tech Act back in whatever year that was, 2009, 2010. So what's going to happen now is there is a new National Health Information Exchange organization entity called TEFCA, and there's a controlling entity that known as the RCE that basically provides governance and oversight. And the idea is to develop regional quality health information networks that take off a lot of the pressure from the local HIE. So the local HIEs really can focus on the regional problems, on the statewide problems, and provide connectivity across regions and across areas. And then ultimately you have participants, which are state and regional HIEs, and then end users who belong to that, various providers. So this is the famous umbrella slide that ONC uses all the time. You may have seen it before, but this is one of the solutions I'm talking about. This was, a recognition that there was just too much fragmentation in interoperability. So let's bring some rationality into a national system as much as we can, and also build out some sort of regional connectivity that will allow the local participating HIEs and state HIEs and regional HIEs focused on their core businesses, including some of those new business opportunities we just mentioned. So that's TEFCA. I mentioned the flattening of the national exchange infrastructure. TEFCA is real and it's in the process of being implemented. There's wide-scale adoption of rules of the road. Care Equality is the entity that is the RCE, and it's got a methodology in place that is essentially what are codifying rules of the road for exchange. So interoperability should be much more easily achieved, and once we have better interoperability, we should have better data integration. We see increased vendor participation in national networks. Once again, I'm not criticizing any particular vendors, but some vendors did go their own way, did not choose to use standards except for qualifying for payments, such as a meaningful use program, but rather built out proprietary networks. But that's really shifting quite quickly as you have all the major vendors now, Epic, Cerner, and the like, participating and committed to making the national networks work. We got the EHX, or the Health Information Exchange, expanding and doing a lot of testing right now. And as I mentioned, InterSystems is the vendor for that. The idea is to reduce hops. I mean, each time you do a hop, each time you connect to a new location, you just have complexity that's introduced. It's like playing the old game of telephone, right? You lose efficiency, you lose data. And so the idea is to flatten the infrastructure. So that's definitely in process. There's tests going on today. COVID-19 and public health, there's money coming, billions of dollars coming. Suddenly the realization of data exchange and integration with public health. In the past, the federal government did not deal with it, in my opinion, in a coordinated way. You have very underfunded and siloed public health systems, and just a general absence of integration. And I mentioned LOINC and SNOMED. That's during last March and April, when, you know, the pandemic was really at sort of the peak of concern and the peak of cases in many large population areas. We became very aware of just how we have to improve the exchange of laboratory data, and also include demographic data. You know, you need comorbidities too. I mean, exchanging data without a patient record, without understanding comorbidities, without understanding demographics, it has limited value. We can count how many positive and negative cases, but we need more than that. And funding has become available, and hopefully it will be sustained. So I'll pause again here and ask if there are any questions. Kelly?
Don't have any posted yet.
Okay, I hope it's interesting. I kind of think it is.
Yeah, we're actually putting some information in the chat also, if everyone wants to check
Okay.
that.
So just talk a little bit about the Cures Act standards and APIs. APIs are really important, application programming interfaces. So the Cures Act rules summary, it requires consumer access to electronic health information. It defines this category of data called electronic health information, EHIE, or as it's being called. And as I mentioned, it mandates that consumers have access to a broad set of data at no charge. I mean, I think now it's looking like a provider can recoup, or a vendor can recoup, you know, the marginal cost, the incremental cost for providing it through open source APIs. And I'll introduce APIs in just a second. And in particular, the standard that's being developed now and adopted now called FHIR, Fast Healthcare Interoperable Resources. Also, the Cures Act rules has that there has to be provide access to provider directories by January 1st, 21. So this should make everybody's life better. If you're a payer in the CMS program, we're going to be able to do some form of attribution based upon claims, and that's really important. And then patient matching. I mean, while there's rules, it still may be more aspirational in that patient matching is still a challenge. And if there's an interest, we could talk about the different and newer methodologies being introduced for patient matching. Information blocking, there's penalties for providers, payers, and vendors if they do not share data. There are exception cases. At this point, if you're identified as an information blocker, the fine is not that substantial, but there is shame. They're using shame as a motivator. And then alerts, much like admission discharge transfers require that hospitals share real-time alerts with community providers. And then we get to application programming interfaces and Uscdi, and I've got a few slides on those. So basically, health information exchange up until about a year ago was driven by the exchange of huge documents. And in particular, one key document, and I'll show you a picture of it in just a second, called the Consolidated Clinical Document. It was a CCD, and it's really developed as the major payload. And I don't know if any of you providers have had any experience in dealing with a CCD, but if you get it in a format that typically you'll get it in a format that has limited parsability and it's very difficult to search. Typically a CCD document will be over 50 pages or 55 pages, I think is the average. So this is under the old model, right? This is under the, I mean, it still works. CCD parsing is improving, but there's a real realization that it was standing in the way of interoperability, having such a large document as the basis of exchange, and it's difficult to use. And there was really no recognition of data utility, no problem list, allergy list, medication list, immunization list, right? I mean, if you talk to primary care providers in particular, PAMI, I don't need the other 55 pages, right? And so in looking at that, the Cures Act recognized that there may be a better solution called application programming interfaces. It's the backbone of internet commerce, and FHIR has evolved as the leading standard. So if you think about it, when you use Travelocity, let's say two large cities, let's say you want to travel from Denver to Los Angeles, and you're looking at flights. Well, you've got United, you've got American, you've got Delta, they're all going to have probably something in those markets or some hub out of. So Travelocity has got this problem of aggregating the important data, right? Think of it as PAMI. Think about it as the key data. But in this case, they want the information about flights from Denver to Los Angeles on a particular day or a particular day part. Now, there's two solutions. Travelocity can download the whole database for American Airlines or United Airlines and do the search and basically replicate it, or it can use a application programming interface that has got permission to go in and query the database for the airline, right? So you see how efficient it is. They go in and they say, Travelocity sends a query to United and says, I want to know about flights from Denver to Los Angeles on a particular day. Well, think about that using in healthcare. You can use an API to basically go to another electronic health record and say, I want the problem list. I want the discharge summary. So what it is, it's no longer document driven, but it's template driven. So this is what a CCD looks like, a continuity of care document. You could see it consisted of 58 different templates: allergies, medication, hospital discharge meds, post-op dictation, and 54 others, right? So all of these templates are part of the CCD. So, but just think about, you're only really interested, say, in the immunization. Well, you can, using an API, you can basically just go in and query for a particular piece of information. Now, this is the other important piece of using APIs, and this is the Uscdi data requirements. This was mandated by the Cures Act and became law, was codified into regulation on March 8th this past year. And if you'll notice, the Uscdi has got just really these key elements in it, right? It doesn't have everything. And what's most important is it's organized in such a way is that an application programming interface can go in and ask for particular pieces of data as opposed to asking for all of that data. That makes, remember we talked about data integration as opposed to data interoperability. That makes the data mapping between the two systems far more efficient. And so this is why there's such an interesting and important focus on APIs right now. And I will point out that InterSystems is a leading innovator in that space. I think what's kind of interesting, if you look at Uscdi, what they've added, particularly to this version, and now what's important about this is all electronic health records have to basically provide these data elements, but they added data provenance because the liability issue of bringing in data from an outside source. I know I've been doing all the focus groups we did and the subject matter expert interviews and various work I've done for the ONC in the past year. When you talk to providers, and I mean, I'm telling you, I'm preaching to the choir here. Let me just say this. It was not unusual for providers to say, well, I want to know where the test came from before I trust it. So now we have data provenance, or the author timestamp, and the author organization all documented with a piece of data. So you know where it came from, you know who the author was, and you know the author's organization. And we think that will help data liquidity and data reuse substantially. Also, pediatrics was notoriously underrepresented in the Meaningful Use program, and so they've added new pediatric vital signs, and there's a whole workforce on pediatrics going on at the ONC right now. And then the clinical notes, so that we basically codified what they contain. So the idea here is we're going to have a whole new, more cost-effective and quicker solution to interoperability, to data liquidity, reducing the friction in terms of exchange. And a lot of this is part of the challenges of what the CCD was developed under, which was the Consolidated Clinical Document Architecture, or HL7 2.x. So, you know, moving to API-based exchanges, it's well seasoned, it works. I heard that when you go onto an Amazon website, that the average Amazon website sends out 54 API queries to bring back data when you see that page. So this is a really well-established, you know, solution. Also, we're looking at modularity, as we looked at in the Uscdi versus documents. We're focusing on high-value information. And then we have this standard that's been basically approved by Health Level 7, which is the standards body, and encouraged by ONC's Interoperability and Standards Committee, called Best Healthcare Interoperable Resources. And what's important is it's open source. It's not owned by a vendor. And we do have a problem of vendors implementing proprietary APIs, but that's a whole other discussion. So we have that. And then we have this whole issue of third-party exchange. Not certain how that's going to evolve, but if you look, you know, perhaps an analog, I think an analog is sort of those ancestry companies, you know, where you can have your DNA check. We just did it for our dogs. Haven't done it. We won't do it for ourselves because, you know, you're signing away your privacy if you do that. I mean, basically, Ancestry and 23andMe can sell that to insurance companies or whomever they want on an identified basis. But anyway, the whole issue of third-party and consumer-directed exchange, where a third party can come and aggregate the data for a consumer and then make that available to whomever the provider wants. Now, we're not going into 42 CFR Part 2, which is behavioral health. Another key interesting piece is adolescence, and what do you do with data for 12 to 18-year-olds where the parents have restricted exchange, and how you deal with that data. But those are really interesting conversations too. So that's basically sort of an update of where things are going. And Uscdi Care Connect, I'll just say, has a real advantage now because they don't have the legacy technology. They don't have the costs with the older systems. They don't have to try to amortize the costs they did for implementing a system that still has a lot of these legacy problems and is costly to upgrade relative to interfaces and the like. So you can sort of leapfrog. I sort of, you know, think of it maybe a goldfish jumping from one bowl to another. I think another analogy is how sub-Saharan Africa never had wireline systems, where if you're able to avoid the fixed costs of a high network, you can just cost effectively move to the next generation. And I think that's where we stand today. So Kelly, Drew, anybody, questions?
We don't have any in the chat right now, but everyone is welcome to unmute if they want and ask questions that way for Dr. Ozanich or for Big Sky in general.
Oh, you know, any questions?
Yeah, this is Sherry Taylor. I have a question. What have you found, like what has been the most cost effective, because you've been in this realm for like 30 years, for medical staff particularly, that has been the advantage for them? Because we just keep piling more systems on them. So what can we utilize as a selling point for medical staff in what the HIE can bring to them?
I think ultimately it's as that data integration is being addressed and the workflow where the utility, particularly in a value-based environment, it makes it worthwhile. I mean, every provider wants to provide the best care they can, no question about it. But making that easier to use data to get the complete picture. You know, the thinking is that, you know, you have the whole idea between all of the investments in the infrastructure was if you build the infrastructure for data exchange and data integration, then you can start to change how we reimburse, right? But now reimbursement's here, you know, value-based care is here, and there have to be some effective solutions. I mean, one of the reasons why I really wanted to address all of the problems of health information exchange in the past is because that's part of the legacy story too, right? I mean, providers have been oversold EHRs. They've been oversold data integration. They've been oversold the ability to integrate care. And I think that the key element is making it easier. I think the vendors, I want to be careful not to criticize any of the EHR vendors, but I think that, you know, walled gardens work in a fee-for-service world, right? And walled gardens work for vendors. But I think in a value-based care world, when you want that complete picture of the leakage and the patients you're losing, it has to be a rational argument. I just finished a big study that was funded on diabetes and clinical decision support and the whole area of clinical inertia. And it's sort of analogous because we couldn't get providers to use clinical decision support, right? I mean, it's another tool. And they did not want to see recommendations. I mean, clinical inertia is well documented that providers will often not know the most current treatments available. There's 120 treatments for diabetes mellitus. The average provider uses the same 3 to 5, and let's use this computer tool. And we found that we really were able to make a quality argument, that quality improved. We had, you know, we improved A1Cs by 2.1 in the measure scale. It's analogous, right? I'm making an analogy here. But in there, I was in the foxholes with the providers, and it's about the patients, it's about the data, and it's about workflow and ease of use, right? So hopefully we're going to be able to bring the data in more effectively and more efficiently, and they're going to see not only the reimbursement piece, but they're going to see the outcomes piece. But you know what, Sherry, I mean, I understand. I mean, it's a challenge, and you just have to, you can't wave a magic wand and say it's all here. But good data convinces docs and all providers, nurses, everybody. I don't know if that's a very good answer, but that's my best.
No, I appreciate that. I think it's what we're going to all struggle with as facilities as we move forward, is what you said. They've been oversold in the past, and now we need to just deliver. And I think that's going to be the big key.
Yeah. Additional questions? Well, I encourage you to follow these developments, particularly in the world of APIs. You know, it's to me, it's just so exciting to finally, you know that a technology works so well on the internet, and hey, we're finally bringing it to healthcare, as opposed to, you know, the big consolidated approach to data. That there is a difference in the utility and value of the data elements in a patient record. And I think that's another key story to bring to providers. And we want to bring those key high value pieces of data to you so you can give your patients better care, and you can also report better outcomes. And it's just a process. I wish I had an easier answer.
Thank you, Dr. Ozanich. We did have a question for the Big Sky team. Can someone comment on the resources available to independent practices?
Yeah, I think maybe Kurt, I think I saw you were on. Jeanette, I'm not sure if that's a question maybe that the outreach team could address.
Yes, this is Jeanette. In terms of, are you asking about technical resources? Because we do provide all of those services as part of the onboarding process. So depending on what kind of resources you have available, we can supplement those resources at a technical as well as a clinical level as well. So I'm not sure if that answered the question, but we can help work through any issues that you have with your EMR vendor, you know, negotiating prices, things like that. So whatever type of resource you're lacking on your side, we can supplement through our team.
Thank you. I'll follow up and make sure that answered the question. Dr. Ozanich, do you mind going to the last slide where it shows the contact information? Thank you. And Drew, I think if there's no other questions, I think we can turn it over to you for a few minutes.
Yeah, thank you. Jeanette, I don't know, did you want to follow up at all on any other comments to that last question?
Thank you. Yes, we also have financial resources available. So as been said in the past, we cover the funding on our side through September of 2021, but we also have a interoperability network assistance program that helps with the cost that if your EMR vendor is charging you on their side. We do have a program for that as well, and we have applications available through your outreach coordinator.
Yeah, thank you, Jeanette. Kara, hopefully that answers your question. If you can feel free to come off mute too if you'd like to discuss further before I go ahead and wrap things up, or if anybody else has any questions. All right, well, Dr. Ozanich, thank you. I think that was a very informative presentation. I would actually like to catch up sometime and hear your thoughts on a number of topics, so I'll just send you a meeting invite and make sure we can connect on that.
Sure, sure. And I hope I get to come out to Montana sometime. I'd love to come out.
Sounds great. Sounds great. All right. So just to wrap up here, so if you would like any additional information, we ask that you reach out to the BSCC team through our website, which you can see there on the screen, along with phone number and email. And our team is ready and waiting. We're here to assist you in any way we can, and hopefully, you learned some great information today about what we're doing here at Big Sky Care Connect, and we look forward to getting all of you connected and being part of this this great initiative. So thank you very much.